Today we're covering a case presentation of a distance runner who had pain into the front side of the hip here. There was increase with bringing the knee to the chest and also with running. Running was becoming very unbearable and not really enjoyable as it should be. So I'm going to cover the things that helped him today, as well as some positive findings that we had in his exam. And I can tell you with full certainty after 3 sessions he's feeling much, much better, and sent a text saying that he has the most enjoyment in the run that he's had in years. We're going to use something like a ball to help address it a little bit later, but in-person manual therapy and things like that can be super helpful. This doesn't substitute for that, but it can be very helpful in the meantime. So this person had signs of hip impingement. So hip impingement, which we've done in some of the other videos, typically presents with pain or limitation as the knee approaches the chest. We can couple this with other movements such as adduction, which is across the body, and hip internal rotation, which further exacerbates and closes that space. I'm not covering a whole anatomy video today. We have tons of other videos on hip impingement. We also have a free PDF at the bottom, or a webinar as well, at the bottom of the description. So what happens here though is it can be anatomically based, but also it's mechanical based. So what we found is that this increased it, this made it feel a little bit better, this was limited in range compared to the other side, and this was a little bit painful to do as well. So what he's done is hip flexor stretching, such as this type of stuff. This didn't help. He's tried glute exercises, he's tried ab ones, and so on. Even imaging was all negative. So what I end up doing, and historically I've found that people with hip impingement sometimes respond really well to pretty aggressive, I don't want to call it cross friction necessarily, but where it's more of a heating up approach of some of the muscles on the side of the hip. So if I turn to the side here, here's that bony bone that everybody has. It's actually up into the back a little bit, just around here. So what I did when he came in, I had him sidelined, and I just took my knuckle and just kind of made some star patterns in there. It took a couple minutes until he felt very, very, very uncomfortable. I think he was about to slap me at the time. But if we're going to do this as like a home version, so what he's going to do is find that area there. And so the big mistake that people make is they just kind of sit on it here. If the point is to heat the tissue up, sitting on it doesn't do anything. Foam rolling it doesn't do anything either, because you're just ironing out the area. Even like a Theragun, or sorry, those massage guns don't really work either, because they don't heat it up quite that much. And ideally we want a friction-based heat, not a heat like a heating pad. So what you can do is just try to back and forth on the area. It's going to be kind of cumbersome, but you spend like 2 to 3 minutes just kind of working that spot out. Most of the time people notice that it's very, very uncomfortable in the beginning, and after about 2 to 3 minutes it starts to cut its symptoms into about half, then it becomes less uncomfortable. So that's spot one. What a lot of people don't know about some of the tissue work is sometimes there's complementary trigger point areas down the leg, and especially on the flip side. So if that area was the back side, there's usually going to be something in the front. And especially since he did have periodic symptoms into the front of the knee, I started to address the area right here, which is called the adductor hiatus. And so the adductor hiatus here, I'm trying to stay away from the nerves, like the femoral nerve that come out of it, but you find right up into here, and then we just took a little knuckle and we just went like that, which is super uncomfortable for him again. So we did that for a couple minutes and so on. Home version, I had him just do this, okay? He's going to do it for about once a week if he's diligent about it. Now the last thing is usually there's like a distal point or some point down the leg here on one of the sides. And so I felt around back here. He didn't feel anything. I didn't feel anything. I even felt around the foot. There's nothing there. And I felt down here. No. Oh, right there, there's something. And so we started to get into that too. Why are these trigger points there? The theory is that sometimes they're leftover compensation from some other old injury. Maybe it was this old injury, I'm not quite sure. But what we would do is just try to heat up and get them to let themselves go. And they may stay gone for quite a bit of time. So if these are the 3 points that we did, he went outside, he was running, and he felt much better. Now, because he did have symptoms into the knee a little bit too, we did something a little bit more creative, which is femoral nerve flossing. I mentioned the adductor hiatus here. He didn't have any positive findings of femoral nerve tension testing, which is a little bit, you'd think you would probably find it. But there's nothing wrong with doing a little traction here, laying on your side, trying to get the leg back as far as you can, and then just kicking like mad. So he did this about once a week, about 30, 40 reps in a day, and things have gone really well since. Now, last thing I'm going to show you is one of the exercises that we did on a cable machine too. This is something that most people won't know how to do, but it can be very helpful to loading the body in the frontal plane because everything in the sagittal plane and transversal wasn't really working well for him. So I'll show you here on this band, and I'll pull it just to the side. So this, I don't prefer it with a handle, but we can do it with a handle. There's something called a physical industry strap where you can do it on the hip. I've showed it in other videos. But basically, what we can do is we can start loading this person in a frontal plane. Now, a lot of people will do what we call Cossack squats. So they'll go here and they'll go up. This is where the knee is over the second toe right there. That's not what we want, okay? That is a sagittal plane loading strategy. That's not what I'm looking for. So in this scenario, I would go pretty wide, and what I'm looking for is the hip, knee, and knuckle are all in line as I go through this pattern here. It's relatively short, but what I'm looking for is to see if I can make sure that person feels strong in all ranges. And I can load this up pretty heavy on them, and I can even lean into them pretty good. But they need to keep me at bay the entire time. So what we did is about 8 reps that were pretty hard for him, 3 sets per side. And that's when he told us he felt really good. He went out and ran after. And then about a week later, we got a text and a picture proving that he felt a lot better. So this is just another way of looking at hip impingement. We loaded him very quickly on day 1, but we got pretty aggressive within a 3-week period of time. And it didn't hurt him to do, but we got to strategize how to get the body to do different things because his default pattern wasn't working anymore. If you guys are looking for help on this or want to know more information, call or email us, 714-502-4243. We do virtuals or in person. We're in Costa Mesa, California. See you soon.